Greetings and welcome back. This is part of the Microbiology for Critical Care series that I've been doing. We've already covered the essentials of identification and classification of bacteria, and today I'm going to go into more depth on some of the medically important bacteria that we are exposed to on a day-to-day basis and need to have an understanding of their basic characteristics and as well what kind of conditions that they can cause, so that you have an approach to dealing with them when you see them. The first part we're going to cover will be the gram-positive bacteria, and then in a subsequent lecture I'm going to go into depth on the gram-negative bacteria, and especially the Enterobacter group. So to start, let's talk about the gram-positive bacteria. The most important bacteria in this group that you're going to encounter is Staph aureus. This is a very common organism and is one of the most frequently isolated in microbiology labs. And is responsible for a number of very important conditions, so it's important that you have an understanding of it. The bacteria is an ubiquitous colonizer of the skin and mucosa of practically all animals on land, but in humans particularly seems to have a predilection for settling in the anterior part of the nose, as well as on the skin. The nose serves as a good warm reservoir for the bacteria, and is also relatively defended against other organisms that it has to compete against. This is relevant when we have to deal with the problems of methicillin-resistant Staph aureus, and the reason why we swab the nose when we're looking for it as part of routine screening is because that's where it tends to reside, and it's also where it tends to persist and is hard to eradicate. As you can well imagine, there are a large number of pathogenic features of the organism that allow it to not only remain as a colonizer, but to gain a foothold when it decides to become the problem child. In general, there are three different groups of pathogenic factors. Those that are related to the cell wall and the polysaccharide capsule, and then also a series of toxins that it can excrete. Cell adhesion is very important because if an organism can't attach itself to an endothelium or to a membrane of its host, then it can't really ever truly gain a foothold. So Staph aureus has a large number of wall-associated proteins that help it in getting its foothold and sticking onto the mucosa and onto the endothelium of its host to gain its foothold so that it can start the infection. As well, there's a polysaccharide capsule surrounding the bacteria that allows it to evade phagocytosis. There are a number of toxins that it can produce. The most common and ubiquitous within the organism is hemolysin, which it excretes in order to defend itself against attack within the bloodstream, and is capable of lysing both red and white blood cells to help it evade host defenses. Now, depending on the specific strain of Staph aureus that's infecting, there are a number of other different toxins that it can produce that it can then excrete to help in its virulence. If it's an organism that has a predilection for the bowel, it can secrete an endotoxin, which has its effect mostly on the enterocytes, and can cause a fairly significant diarrhea. There are a number of other strains that are responsible for producing toxins that can generate mucosal and skin changes, particularly the scalded skin toxin, as well as the toxic shock toxin. Scalded skin toxin is affects the epidermis and causes a generalized sloughing, whereas the toxic shock toxin is actually a superantigen that not only causes skin and soft tissue effects, but also hyperactivates the immune system and causes a significant SIRS reaction. Now, depending on your location, the antibiotic spectrum for Staph aureus will vary. This is the antibiogram for the University of Alberta Hospital, and you can see that we continue to have a high level of sensitivity of Staph aureus to vancomycin, but have about a 21% rate of methicillin-resistant Staph aureus, as marked by the cloxacillin sensitivities. Fortunately, it still remains sensitive generally to linezolid, but much less so over time, as it's developing more of a resistance to clindamycin. Now, there's a number of clinical syndromes that are associated with Staph aureus infections. Starting from the outer layer and working inward, skin and soft tissue infections are very common and commonly caused by Staph aureus. This is understandable, since this is where the organism resides on a regular basis as a colonizer, and only when specific strains become predominant can it start to, or when there's a break in the mucosal barrier, can they start to have problems with skin and soft tissue infections. As I've said, depending on the specific strain of bacteria and whether or not it's producing a specific toxin, you can also have a scalded skin syndrome, or even a more severe toxic shock syndrome. Now, once the bacteria has gained a foothold and it's in the blood, it can cause all kinds of trouble throughout the body. It has a particular predilection for the heart valves, and can set up on the valves as an endocarditis. And this is a particularly nasty infection to get, as it's very aggressive. And once the organism has started burrowing into the cardiac skeleton, can actually cause the valves to not only just leak, but also the entire heart to fail, or even invade into the conduction system. It can also cause an osteomyelitis. These people can present more subacutely, episodes of bacteremia that have seeded into the bones, developing over time a progressive bone, or in the case of arthritis, a joint pains associated with the infection in the bone or the joint itself. Septic arthritis tends to present a lot more acutely, whereas the osteomyelitis will tend to be a bit more of an indolent course, much harder to detect. Certainly, anytime when you've had a patient who has Staph aureus in their blood, you need to go back and not only consider whether they have infection on the heart valves, which may be serving as the source, but also look for any evidence of any bone or joint infections that could also be acting as a source of infection, or conversely as a complication of the bacteremia. Finally, there's it can become resident in hospitals more particularly as the MRSA strain, because of selective pressure. And once it's becomes part of the overall environment within a hospital, can then become a colonizer of the oral pharynx and make its way into the lungs and cause hospital-acquired pneumonias. This is one of the reasons why it's important that you know what your overall antibiotic spectrum is for your location, so that you can anticipate the appropriate treatments for these, and also have a sense of whether or not the rate in which you have infections or pneumonias that are being caused by Staph aureus. So now, staying within the Staph species. Staph epidermidis is the next organism I want to go over. This is the most common coagulase negative Staphylococcus. There's a large family of Staphylococcus that are coagulase negative, but Staph epidermidis is the most frequently cultured. This organism, as you can well guess by its species name, primarily resides on the skin and the mucous membrane, and generally is considered just a colonizer. It doesn't usually cause a lot of problems, but once the mucosal barrier is breached, it can then become the source of troubles. The reason why it's a problem, even though it's a more indolent problem, is because of its ability to generate biofilm. Now, the biofilm is this mucin polysaccharide secretion that is created that allows it to basically hide itself under cover and evade the host defense systems. It allows it to shelter itself from phagocytosis and then persist for prolonged periods of time. As well, it also has adherence factors that not only allow it to adhere to host structures, but also even to foreign bodies. And this is where Staph epidermidis is the problem. This is the organism that's most likely to cause a catheter-related bloodstream infection, as it colonizes and then forms a biolayer on catheters such as central lines or any other prolonged intravascular device, and then can evade the defenses by the use of its biofilm and can just become a persistent source of infection. These people usually are just generally sick over a more indolent period of time, and will only defervesce when the actual foreign body is removed, in addition to the organism that's colonizing it. Staph epidermidis is a relatively resistant organism and doesn't respond well to cloxacillin, as you can see on this antibiogram, but has remained very sensitive to vancomycin. And this is the reason why vancomycin is often given prophylactically or even empirically in the cases where somebody is suspected to have a catheter-related bloodstream infection. So now those are the two main staph species that I wanted to cover. Now moving on to the Streptococcus genus and cover some of the important Streptococcus organisms that you're going to come across. Now recall that these are all gram-positive bacteria. They're all both staph and strep are both coccus in shape, and the only distinguishing characteristic under a microscope is that staph aureus tends to form in clumps, whereas Streptococcus will form out in chains, so strips of Streptococcus. Probably the most worrisome Streptococcus you're going to encounter is Streptococcus pyogenes, also known as Group A strep. This organism is not a colonizer, although it can reside on skin surfaces, but when it does, it's considered pathogenic and a problem right from the outset. This is an important organism because it has a number of different virulence factors which allow it to not only cause problems but evade detection as well as evade the host defenses. They have a hydronic acid-based capsule which is exquisitely designed to help it evade phagocytosis, and also produce a large number of different toxins and proteins and enzymes to help it in its virulence. The three most important toxins are endotoxin A and C and streptolysin S. Now, exotoxin A and C are both superantigens that are responsible for causing a toxic shock-like syndrome. So, presenting in many respects similar to Staphylococcus toxic shock syndrome. These are similar types of superantigens that cause a very similar type of syndrome. The difference being these strep tends to be first causing a soft tissue infection, and so there's usually some evidence of its location and then the toxic shock that comes from it, whereas Staph aureus can just be resident and then start causing troubles. Streptolysin S is a particularly dangerous exotoxin that's specifically cardiotoxic, which not only attacks the heart itself, but also can attack many other cell types and cause a whole host of troubles. Now, strep this form of strep has the ability to evade a large number of host defenses through a number of fairly slick methods. They produce a streptokinase, which you'll recall is actually one of the first antifibrinolytics used for myocardial infarctions. And this streptokinase activates plasminogen to digest the fibrin. This allows it to evade the host defenses, part of which includes the actual formation of clotting around locations of infection to try to wall off the infection and try to keep it under control. It'll produce streptokinase to actually break through these barriers so that it can continue to get out and cause all kinds of trouble. As well, it has the ability to, it also will generate a C5a peptidase, which is, C5 is one of the complement factors, which we'll talk about in the immunology area. And this peptidase is able to cleave the C5a molecule, which then acts as a neutrophil chemotaxin, and by cleaving it, removes one of the signals that the neutrophils require in order to identify and then move towards sources of infection. So, in a sense, jamming the danger signal that's going out from the infection. As well, the serine protease SCPC degrades IL-8, which is another interleukin factor that helps with neutrophil attraction, and so by degrading this, decreases prevents the ability of neutrophils to identify that there's trouble and then start making their way towards the source of the problems. So, a particularly dangerous organism which not only causes a lot of problems but also has a number of eloquent ways of avoiding the host defense systems. It causes a large number of different infections that you need to be aware of. Probably the most common in outpatient is it can cause an acute pharyngitis, and is the most common bacterial cause of acute pharyngitis. It can be an issue in that depending on the types of toxins it's producing and also the host immune response to it can lead to the autoimmune condition of rheumatic fever or post-streptococcus glomerular nephritis. Certainly, both scarlet fever and rheumatic fever, as well as post-streptococcus GN, were much more common in the pre-antibiotic era, as the only way the organism could be rapidly cleared was through the host immune system, which, given sufficient time, often became its own source of problems by misidentifying both glomerular and cardiac tissue or heart valve tissue, and mistaking it for non-self, and then attacking it in an autoimmune way. Fortunately, this is much less common these days, as rapid identification of strep throat leads to earlier initiation of antibiotics. It can cause a number of soft tissue infections, erysipelas and cellulitis being more common, but more concerning. These infections can get into the deeper tissue planes and can even cause a necrotizing fasciitis, given the toxins that it's capable of producing. The Streptococcus toxic shock syndrome is then the final step on the spectrum of skin and soft tissue infections from this, as more of a consequence of the immune reaction to the infection itself. Now, Viridans group Streptococcus is another large group of Streptococcus species that are generally, again, quite indolent and are not really considered a particular problem on most days of the week, but given the right circumstances can cause their own troubles. The bacteria likes to inhabit the upper respiratory tract, as well as the female genital tract and the GI tract and the mouth, and just generally just kind of hang out and not cause too many problems. It's considered a low virulence organism because it doesn't actually produce any endotoxins or excrete any exotoxins, and really its major virulence factor is the makeup of its extracellular dextran on its outer surface, which makes it particularly sticky to the to heart valves and has an important role in causing endocarditis. So the organism itself, from any number of different events, such as even routine dental cleaning or endoscopic procedures, can cause brief bursts of bacteremia, which, given an otherwise compromised heart valve, it can stick to and then take up residence and can cause a indolent endocarditis. The organism is not as sensitive to penicillin as its cousin strep pyogenes, but remains again very sensitive to vancomycin as well as ceftriaxone. Next, I want to cover another Streptococcus-like species, which is actually now broken out into its own genus, the Enterococcus group. This was originally part of the Streptococcus group, but based on characteristics and molecular techniques, has now been placed in its own group. Enterococcus is essentially an organism of the GI tract, as its name implies. It's very well adapted to living life in the human GI tract, particularly in the colon, and will generally cause no problems for the vast majority of people, but only becomes an issue when it gets into places where it ought not to be. It can get into the urine, into the urinary tract system, as a common infector of the bladder. However, it is much more of a problem when it is exposed to antibiotics. Now, it's intrinsically resistant to many different types of antibiotics. And it's not that it actually is affected by the antibiotics, it's that the other organisms that reside in the bowel as part of the normal flora have their composition altered. And the balance of power in the colon then tilts towards Enterococcus. In addition to that intrinsic resistance to many antibiotics, it also has the ability to recruit a number of different antibiotic resistance genes, which allow it to then express increasing resistance and not necessarily to antibiotics they may be exposed to. So, for example, if somebody's taking a third generation cephalosporin, they may, in doing so, recruit the expression of vancomycin resistant genes as a consequence. As you can well imagine, it has well adapted itself to life in hospitals because of the presence of antibiotics to produce both resistance within and also alter the balance of power around it, and can then be easily spread throughout a hospital. Outbreaks of vancomycin-resistant Enterococcus are unfortunately becoming increasingly common and are very hard to control within hospital environments. Now, there are two main species of Enterococcus that you should be aware of, Enterococcus faecalis and Enterococcus faecium. Enterococcus faecalis, much more indolent, much less of a problem, also much more sensitive, as you can see, to a wide variety of different antibiotics, including vancomycin and linezolid and ampicillin. The bigger brother of the two, faecium, is much more of a problem because it has a larger number of resistance factors, and so is the one that is responsible for vancomycin-resistant Enterococcus, in addition to a higher level of resistance to ampicillin. Both of these organisms can cause similar clinical syndromes, and the ones that you need to be aware of are the possibility of developing a bacteremia and then subsequently an endocarditis, and then more concerningly, more resistant hospital-acquired urinary tract infections can be encountered, especially, as I've said, in the hospital environment where there's a lot of antibiotic pressure on other organisms, as well as allowing it to express inducible resistance chromosomes. So the last Streptococcus I want to talk about, and the last organism I want to cover in the gram-positive family, is Streptococcus pneumoniae. As its name suggests, it is more of a problematic organism for pneumonia, and it has the ability to colonize the nasopharynx, although really it shouldn't do that because that's just giving it its portal of entry into the lower respiratory tract. Probably its most important virulence factor is a capsular polysaccharide, which prevents phagocytosis and activation of complements, and helps protect it against the host defense systems. It also produces a pneumolysin, which is a cytotoxic directly, and also can activate the complement cascade. Finally, it also produces two factors, PSPA and PSAA, which inhibit phagocytosis by blocking complement deposition on the bacteria, and also by mediating adherence to allow it to stick to the host endothelium. This is another organism that it is important to know your local antibiotic sensitivity patterns and antibiograms, as the sensitivity of Streptococcus pneumoniae to penicillin is a rising problem in certain areas. Currently in central and northern Alberta, the resistance to penicillin hasn't been as much of a problem, and certainly, as you can see with non-meningitis dose of penicillin, we still have a fairly high level of sensitivity to that. In other parts of Alberta, particularly in southern Alberta, the resistance to penicillin is significantly higher and much more worrisome. Fortunately, vancomycin still remains the go-to drug of choice, especially when you're dealing with more serious infections. The three most important infections you should worry about when you encounter Streptococcus, and it can cause a bacteremia and can often be identified first in the blood, is community-acquired pneumonias, meningitis, and then more fulminant otitis medius. these are not necessarily either-or syndromes, and it is not uncommon for you to encounter a patient who has both pneumonia and then as a result of the bacteremia and secondary spread to the meninges to then have the patient also develop meningitis. So certainly anytime you have encounter a patient who has pneumococcus bacteremia, you need to be absolutely certain that your coverage is adequate for meningitis, and then you also need to do follow-on investigations, including a lumbar puncture, to make sure that indeed you've ruled that out. And you can't simply assume that the bacteremia is just a result of the pneumonia that's plain as the nose in your face on the chest x-ray. So that's all there is to it on our brief romp through the gram-positive family. As usual, if you have any questions or issues, please don't hesitate to contact me or leave comments in the section below. In the next section, we'll talk in detail about the gram-negative bacteria